So we are going to start our morning first scientific session. We have other session, the cultural reviewing, inaugural session, and the gala dinner that will be in the second part of the day in the evening. So ladies and gentlemen, my students, my colleagues, and all others, I welcome all of you in the scientific session, and we are going to start the first scientific session. Thank you.
Thank you, sir, for your hearty welcome. As you know, liver cancer is a very prominent cancer. It is the 5th most common cancer throughout the world. So this is a very important event that Bangladesh is going to organize, an international event on liver cancer treatment and research. And we are going to start our first session. Our first session is on the topic of diagnosis and approach in hepatocellular carcinoma. We have three honorable speakers here. First topic is diagnosis in hepatocellular carcinoma, and the speaker is Dr. A.K. Moinul Hussain. Second topic is the art of pathology and immunohistochemistry journey, and the speaker is renowned Professor Ghulam Mostofa. And our third speaker is Professor Selimur Rahman. He will talk on very important topic on multidisciplinary approach to HCC. Chairperson of this session is Professor Chittoranjan Debnath, Professor of Hepatology and ex-principal Mymensingh Medical College. I would like to request Professor Chittoranjan Debnath to come over the dais to chair the session. Sir, please. Now time for topic presentation. As I said, our first topic is diagnosis in HCC. I would like to request Dr. A.K. Moinul Hussain, Senior Consultant Radiology, Labit Hospital Limited, Dhaka, to present the topic. Dr. A.K. Moinul Hussain.
Bismillahirrahmanirrahim. Good morning, distinguished guests, ladies and gentlemen. I'm Dr. A.K. Moinul Hussain, and I'll be going to talk about the role of diagnostic imaging in HCC detection. So the objective of my presentation to see the efficiency of different modality for early detection of HCC and to see the post-therapy response, including residual, recurrence, or relapsing disease, and to aid different modality in minimal invasive surgery like TACE, radiofrequency ablation, and microablation therapy, etc. As you know, all the modalities are now present in our country, and the functional modality, that is the PET CT scan, is also available especially in Dhaka and also in Chittagong and Savannah as well. So for the HCC detection, I think the screening imaging modality is definitely the ultrasound. And I'll talk about the other modality on the next slide. So these are the modalities. You already know about these modalities. The ultrasound, this is easy, available, costing is very low, and the advantage is there is no radiation. And whenever on ultrasound we find a liver as well, and that is suspicious for any malignancy, usually the consultants or the physicians, they recommend next the triphasic CT scan. But the CT scan is relatively higher in cost. It has radiation, so we cannot use it in pregnancy. And beyond CT, we also use another modality you already know about, MRI, that is relatively higher in costing, but the advantage is it has no radiation. Even we can use it in pregnancy. And the functional modality, that is PET CT scan, that produces the fusion images. It is selectively we use this modality in case of HCC because of high radiation, costly, and especially in case of HCC, if we want to see the other systemic involvement or for staging, and especially after any therapeutic procedure, we perform the PET CT scan, or we usually use this modality. So this diagnostic procedures, this is the common practice that we, especially I'm talking about CT scan, MRI. So we perform both plain and contrast study for detection of HCC, and the patient should be in fasting prior 4 to 6 hours, and the day before, at night, the patient should take the low residual diet so that the bowel gas doesn't compromise the image quality. And in pregnancy, we don't perform the radiation producing modality, that is X-ray, CT scan or PET scan, but definitely ultrasound and MRI are safe in pregnancy. And another important thing is, before going to the procedure, we should ask the patient about if he or she is known allergic to iodinated contrast material. And as you know, if there is any renal dysfunction or abnormal or high creatinine level, or in case of chronic renal disease patient, we cannot use usually the contrast materials. But nowadays, there is availability of isotonic contrast. And even in case of high creatinine level, we can use this isotonic contrast. It is named as VCPAC. And nowadays, the physician, they are also, prefer this contrast in case of renal dysfunction. But it is relatively costly than the available other iodinated contrast. So especially for HCC, the key points for image interpretation, what we see actually in the image, we must exclude the features of CLD or cirrhotic change in the liver, and to see the evidence of fatty change and the severity of the fatty change of liver, and to see if there is any splenomegaly to rule out portal hypertension, if there is ascites and the amount of ascites. And another thing is very important, that is if there is any portal venous dilatation or evidence of thrombus. So as you know, if there is portal vein thrombosis, we cannot do some of the therapeutic procedures like TACE, we cannot perform it. And we need to differentiate regenerative nodule, especially we see it in the chronic liver disease or in case of cirrhotic liver. So we must differentiate from the regenerative nodule and HCC. And in the later, in my slide, I'll show some pictures, how we differentiate and the enhancement pattern. And another important thing is to exclude esophageal varix, which is very important. And if there is any feeding artery to the HCC, so that will help, especially in the procedures like TACE. So in this picture, you see the typical HCC cases, and you see this is the arterial phase. As you can see, the enhanced abdominal aorta, and here you see the larger lesion. Of course, we have some other lesions, but the larger lesions, it has heterogeneous enhancement in this lesion, and also the hyperdensity as the cystic component or necrosis. So this is the arterial phase, and this one is the delayed phase. In case of typical HCC, we see the heterogeneous enhancement on arterial phase, but we find washout. As you can see that it has become darker. So in delayed phase, it is showing typical washout that goes in favor of HCC. And this is the protovenous phase. So fatty liver is a common problem. Most of the physicians, including other specialties, they also face, and ultrasound, frequently they find the report with fatty liver. So on CT scan, how do we detect the fatty liver? As you can see, this liver parenchymal attenuation or density, this is the arterial phase. We also see the plane as well, but if you compare the tissue attenuation or density with the other soft tissue like spleen, as you can see, the splenic parenchymal density and the liver parenchymal density is totally different. This is darker, this is hypoattenuated. That goes in favor of fatty liver, and you can also see this prominent portovenous radicals on fatty liver. But in normal liver, we don't see this prominence.
differentiated hepatocellular carcinoma. But for poorly differentiated hepatocellular carcinoma, it is very difficult to differentiate from metastatic disease. In histology, we have only a few criteria. So loss of portal tract is the most vital event for diagnosis of hepatocellular carcinoma. That means gain unpaired arteriole, tiny hepatocytes. The smaller size of hepatocytes are virtually diagnostic of hepatocellular carcinoma, and cytologic architecture. This is a 60 years old male, and these are cirrhotic nodules. Now, when there is cirrhotic nodules, and at the same time there is a disproportion between portal tract and central vein, it is a very likely chance of hepatocellular carcinoma. And here it is a very big nodule, and only arterioles are seen, no portal tract. So it is hepatocellular carcinoma. This is the normal lobular architecture, and in the normal lobular architecture, we always find portal tract, central vein, portal tract, central vein, like this. Even in needle biopsy, we see alternate portal tract, central vein, portal tract, central vein. And if in a needle biopsy, we see only central vein or only portal tract, it is problematic. Now, immunohistochemistry. Why we need immunohistochemistry in diagnosis of liver tumor? Actually, nowadays, due to we are going for personalized medicine. So accurate diagnosis is very important. If we make a diagnosis of hepatocellular carcinoma in a patient of metastatic carcinoma, the whole treatment, the whole thing will be changed, and the patient will not get adequate treatment or enough treatment or appropriate treatment. So that's why immunohistochemistry comes up to play its role. Now, what is immunohistochemistry? Actually, the term immunohistochemistry, it is a fusion of three things. One is immuno means antibody, histo means histology, and chemistry means reaction or color. So it is a fusion of antibody, histology, and color. So these three things. And there are some assumptions. For each tumor, each cancer produces specific antibody, specific antigen. That is the actually assumption. So this one is a cell. The white portion is nucleus, the blue portion is cytoplasm, and there is a cytoplasmic membrane in the outside. Now, this one is a cell with particular antigen. We have known antibody. So if we put antibody, the green color is antibody, and if the antigen and antibody are complementary to each other, then there will be antigen-antibody reaction or antigen-antibody complex formation. But this antigen-antibody complex is so small, it cannot be seen. So we then put another antibody. That antibody is against the primary antibody. So it is called secondary antibody. So here you see this is the antigen, then the primary antibody and secondary antibody, and if the whole reaction occurs, then we put a chromogenic substance on it so that it develops color. Now, on the basis of the whole exercise, we can have 5 types of reaction. This one, the first one, the nucleus takes stain. So it is nuclear positivity. There are some antibody, as for example, the TTF1, which is a marker of lung cancer, lung adenocarcinoma, that is the nuclear stain. So it is nuclear positivity. The second one, nucleus did not took stain, but the cytoplasm took stain. So it is cytoplasmic positivity. The third one, it is negative because no nuclear stain, no cytoplasmic stain. The fourth one, it is membranous stain. The nucleus is normal, the cytoplasm did not took stain, but the membrane took stain. So it is membranous. HER2, we know the HER2 stain for breast cancer and stomach cancer. This is the characteristic of membranous staining. And the fifth one, it took both nucleus and cytoplasm. So it is combination. There are certain markers, they show both staining. So these are, this table shows the characteristic of different types of hepatocellular markers. HepAR1 is a very nice marker. It is positive in oil differentiated hepatocellular carcinoma, but in poorly differentiated carcinoma, it is negative. For poorly differentiated carcinoma, we have another marker, it is called Glypican-3. So we can use these two and we can make a diagnosis of hepatocellular carcinoma in any event. There is another marker, arginase-1. It is also a very good marker. This is a table we can to differentiate oil differentiated hepatocellular carcinoma, hepatocellular adenoma, and high grade dysplastic nodule. And this is the algorithm for diagnosis of metastatic tumor in liver. So by seeing histology, we can go, or we can think that we should go for this type of marker. We can use this type of marker. As for example, for sarcoma, Vimentin S100, these are positive. For lymphoma, LCA is positive. And if LCA is positive, then we do subsequent markers for classification or subclassification of lymphoma. Then for melanoma, S100. For mesothelioma, this group of antibodies. For squamous cell carcinoma, CK5, P40, P16. For neuroendocrine carcinoma, synaptophysin, CD56. For metastatic adenocarcinoma, we have two very important markers, CK7 and CK20. So there could be 4 types of reaction on the basis of CK7 and CK20. There are in some condition both CK7 and CK20 can be positive. CK7 positive, CK20 negative can happen. CK20 positive, CK7 negative, or both negative. So there are conditions where we can make combination and permutation to make the diagnosis. There is another problem. There are some carcinoma which are known as hepatoid carcinoma. They have morphological similarity with hepatocellular carcinoma, but practically they are not hepatocellular carcinoma. They are metastatic tumor from pancreas, from breast, from colon, from stomach. So these are the organs, they can produce hepatoid carcinoma. So this is how we can differentiate hepatoid carcinoma from hepatocellular carcinoma. Pancreatobiliary adenocarcinoma is an important problem to make differentiate from hepatocellular carcinoma, and this is the algorithm we can make difference between pancreatobiliary adenocarcinoma and hepatocellular carcinoma. Hepatocellular carcinoma and metastatic carcinoma, this table we can differentiate, and we can pinpoint the primary from this table. We can use specific markers and we can go for, as for example, for breast, we can use GETA3. For colon, we can use CDX2. For thyroid, TTF1. For lung, adenocarcinoma, TTF1. For lung, squamous cell carcinoma, P40. For ovarian serous carcinoma, WT1. For prostate carcinoma, we can use, we can have markers. For renal cell carcinoma, we have specific markers. So all these things are available with us. So take home message, immunohistochemistry plays a crucial role in the diagnosis and classification of liver tumors, and also immunohistochemistry aids in differentiating various tumor types, subtyping of tumors with overlapping histologic features, and also predicting prognosis. Thank you very much.
We are very much honored to get eminent Professor Ghulam Mustafa sir among us to present a very interesting and important topic for diagnosis of hepatocellular carcinoma. I must pick a word from sir, personalized medicine. Yes, we are going towards personalized medicine nowadays, and immunohistochemistry plays a very important role regarding this. Some slides, especially to differentiate primary hepatocellular carcinoma from secondary metastasis, it is very much important to know, and it can change the diagnosis, change all the treatment modalities. Thank you very much, sir, for very elaborate and informative presentation. Our next topic is multidisciplinary approach to hepatocellular carcinoma. Our renowned professor, respected teacher, Professor Salimur Rahman sir, President, Bangladesh Society for Liver Cancer Treatment and Research, is going to present the topic.
Thank you, Dr. Ruxana, for a nice introduction. And I have been given the responsibility to talk on multidisciplinary approach to hepatocellular carcinoma. First, I should give some introductory talk that our organization, Bangladesh Society for Liver Cancer Treatment and Research, was formed on this basis. We are keenly interested to treat hepatocellular carcinoma in a multidisciplinary approach. For that, we formed our organization, and we hope to proceed forward with all the related specialties for the better management of the hepatocellular carcinoma. As these are repetitions, as we know, most of the primary liver tumors are hepatocellular carcinoma. This is more than 80, and it is the 5th or 6th cancer burden all over the world, and it is the fourth most common global cause of cancer-related death. So you can understand they're very close to incidence and death. So it is a very serious cancer, and the death rate is very high. And most of the liver cancers occurs in the low resources countries like Asia and some of the African countries So we must be very alert, and we were very much acquainted with the management of hepatocellular carcinoma in this country. And you can see this is the incidence, as I have already said. You can see the Asian countries, Mongolia, Eastern Asia, Southeast Asia, these are the prevalent area. And in Africa, you can see some of the countries are very prevalent. And this is the death global mortality. You can just imagine that where the incidence is high, the mortality rate is high in those countries. This is also the age standard worldwide incidence of hepatocellular carcinoma. You can also see the same thing, the death and the incidence and the death rate, and more in Eastern Asia, the Northern Africa, Micronesia, the Southeastern Asia, and Melanesia. Micronesia, Melanesia, and Polynesia are the small islands together around Australia in the Pacific Ocean. This is the risk factors. The black one is alcohol. You can see it is much more in European countries, and the yellow and the green one is B virus and C virus, and you can see this in the same in Asian countries, the Central Asia, in Mongolia and Southeast Asia, and you can also see in some of the African countries, which countries are not Islamic countries, they consume much alcohol, so it is also common in some African, this is much common in European countries, alcohol-related liver cancer. And you can see the black one in European countries, and it is very minimum in Asian countries, and nowadays it is gradually increasing after increasing the consumption of alcohol. And most prevalent in Asia is the B virus and C virus, and these are the cause of hepatocellular carcinoma in eastern region. And this is the very simple slide. You can see the healthy liver, normal liver. Next stage is chronic hepatitis, and the next is fibrotic liver, and then cirrhotic liver. You can see the very ugly liver, cirrhotic liver with one S-well in the center. In Bangladesh, this is one of the among the top 5 cancers in terms of incidence and mortality, and it is gradually increasing at the rate of 2.5% annually. What is the cause, risk factor in Bangladesh? As we have already said, that hepatitis B and C is the main virus is the main causative factor. Cirrhosis itself can also cause hepatocellular carcinoma, and there is increasing incidence of alcoholic, non-alcoholic fatty liver disease, and also consumption of alcohol, which is gradually increasing. Aflatoxin is one of the important exposure, mainly in the contaminated food items. Other risk factors are T2DM, obesity, smoking, and genetic predisposition. This is the graphical representative. As we all know, BCLC stage 0, A, B, C, and also in some of the organization, EASL, American Association for the Studies of Liver, and some other organization, Chinese organization, more or less follow the principle that in early cases we do either resection or ablation, but in BCLC-A we can also do resection, but we can also do liver OLT or orthotopic liver transplantation, and in late cases we have TACE, and we have also tear in late cases, but in cases of BCLC-D, only palliative best supportive care is the treatment. Now I am coming to my main discussion. There is a multidisciplinary approach. In multidisciplinary approach, we multidisciplinary expertise sit together and take the take the optimal decision, the correct decision for the comprehensive care of the patient, and to support and for the well-being of the patient, best possible well-being of the patient. Then let us meet the multidisciplinary team. Who are included in the multidisciplinary team? First, this is a graphical presentation. This is hepatologist. Next is the radiologist, and the next is pathologist. They together make the diagnosis, And then come the hepatobiliary surgeons. They do the surgery. If a patient needs, they can do resection, they can do liver transplantation, and this surgery is possible in ACC. And then comes the interventional radiologist, and then next come the medical oncologist, then comes the radiation oncologist, then palliative care specialists, they can give palliation to the patient. And another very important part of the team is nurse. And another is psychosocial support is very important, especially in late cases. So multidisciplinary approach with these members is very important. They usually sit regularly together, and first the hepatologists, radiologists, pathologists play a key role in grading and staging the tumor and exploring the extent of the liver damage to help surgeons and other MDT members, multidisciplinary team members in the treatment of hepatocellular carcinoma. What is the benefit? The benefit is there is collaboration. We sit together, there is good collaboration, there is comprehensive management planning, there is tailored treatment, that is you can give the exact treatment which one is needed for which patient. There is time saving, you can give call to different specialties. It takes time, 2 days, 3 days, 7 days, but within half an hour you can sit together and make a decision. Access to the clinical trials. You can do clinical trials by sitting together, by exchanging views, and this is a very integrated treatment, and this is improved outcome and survival rates and enhanced patient satisfaction. You can see that some of the patient was telling you that I had a medical board for the management of my father, so they feel very confident, and they also feel very proud to have a medical board that their father or themselves or their mother is being treated by a medical board. The role of what is the role? I have said the members, and what is the role of them? First, the role is by the hepatologists, that they investigate the liver disease and the extent of the liver disease. They investigate for viral markers, viral hepatitis. They also investigate for the stage of the cirrhosis. In each stage of the cirrhosis, patient is suffering. Then comes the role of hepatobiliary surgeon and surgical oncologist, and they give the curative liver resection or they do liver transplantation whenever it is necessary. Another member is radiologist and interventional radiologist, and they do the RFA, they do the microwave ablation, they do the trace, and they do the tear, and also the SART. In some of the advanced cases, we cannot do TACE, especially in portal vein thrombosis, as my pathology colleague was telling. In those cases, we use TR and SART. And radiology specially provides the image interpretation for treatment planning, response evaluation, and performs the radiological interventions, as I have already mentioned. And hepatologists and also help in this procedure. They work together and do the procedure. And then comes the medical oncologist, radiation oncologists. They do the systemic therapy, that means targeted therapy, and immunotherapy. Immunotherapy nowadays is very important. We should know about immunotherapy. And I attended a conference in Japan on hepatocellular carcinoma, and most of the people I have seen, they were talking on immunotherapy, either single or in combination with other modalities. So all of us should know about the immunotherapy, which is gradually becoming popular nowadays. And radiation therapy is also needed, and we usually do not use systemic oncology because it is very toxic, and we use the targeted one. EBRT and SBRT is also important. What is the role of pathologists? I should not elaborate. Their role is very crucial. They do the histology, they do the grading, and they also do as my colleague said, immunohistochemistry, which is very important in diagnosis of hepatocellular carcinoma. What is the palliative care specialist? And in our country, palliative care specialist service is gradually becoming popular and becoming important. They give the patient improved quality of life in managing the symptomatic relief of the patient, providing emotional support, and sometimes in some of the countries, the end-of-life planning is also given by them. And this is the gist of the MDT team. And this is the tumor. First, we do the tumor staging, and then liver function we assess, because you cannot give all the treatment when the liver function is poor. And we then we set the treatment goal. MDT board meeting is there, and discussing treatment option, shared decision making with the patient, final decision about treatment option, undertaking all factors. And last of all, I want to give idea about some of the cases where in some cases we do resection, in some cases we do immunotherapy, some cases we do TACE, we do in some cases TACE and ablation together, in some cases only systemic therapy. The first case is a male patient, early case of cirrhosis, B virus, and this case was selected for resection, and as you know, the patient is suffering from B virus, so it was evaluated and B virus treatment was given, and adjuvant therapy, if needed, was also given. The case 2 is a case male, and the tumor is a bigger one, and in this case we selected to do combined ablation therapy and TACE, and first TACE was given, then in some of the isolated lesions ablation therapy was also given. And this patient is a case of NASH, so refer to diabetes control is important, and also refer to endocrinologist for the management of diabetes. And the third case is also a hepatitis C. We must see the activity of the hepatitis C and treat that, and that case is also advanced in both the lobes and also vascular involvement. So we did the TACE and followed up case, and hepatitis C treatment was also adequately given. The fourth case was a very advanced case, and it was only possible to give the systemic therapy, and we choose to give 3 options: sorafenib, lenvatinib, and there is also thinking of immunotherapy, but this patient thinking all the factors, we advise sorafenib and the ongoing treatment of hepatitis B. And so we do practice in this country about it like this, and we have a medical team, board team, multidisciplinary team. You can see the activity of our team sitting together with the patient, discussing about the management and giving decision. Thank you all. Thank you for your patience hearing.
Hepatocellular carcinoma, from diagnosis to treatment and follow-up. Definitely it is a multidisciplinary approach, and to ensure this multidisciplinary approach was the motto to form the organization BSL-CTR. Thank you, Professor Salimur Rahman sir, for defining the role of every discipline for management of hepatocellular carcinoma. This is now time for question answer session. If you have any question, please raise your hand. There is microphone over there. As we are lagging behind our time, only 3 questions will be accepted. Dr. Pankaj, there is microphone over there.
Thank you. Thank you, sir. My question to the Monir Hussain sir. You giving the nice presentation in short, the radiology in diagnosis of HCC. My question is, how will we differentiate the regenerative nodule from the HCC? You have already told the regenerative nodule take enhancement in arterial phase, but what is the radiological feature of regenerative nodule in subsequent phase?
Thank you. Can you hear me? Okay. Thank you, Dr. Pankaj, for your nice question. As I mentioned previously, that the regenerative nodule, it doesn't take any enhancement on arterial phase. But in case of HCC, typically it takes the heterogeneous or sometimes homogeneous type enhancement, and that is the HCC, it is wash out on delayed phase. But regenerative nodules, sometimes it persists. So, and if you see the history of the patient, and if you see the other features of CLD, or if patient has other predisposing factor like viral infection or anything, that is also important for us. And we consider everything, and that is the key point, that it doesn't take any enhancement on arterial phase. But HCC, definitely it will take enhancement, and it will be washed out on delayed phase. So that is the differentiating point. Okay. And usually the regenerative nodules, it is diffuse type, but we also get, the diffuse HCCs, but that is relatively, uncommon. But regenerative nodules are, it is diffuse and multiple all over through the liver parenchyma. Thank you.
Okay. Thank you, sir.
Any more question?
Thank you. I'm Dr. Sabrina, resident radiology and imaging from Dhaka Medical College Hospital. Sir. Sir, my question is for Dr. Moinul, sir. Sir, my question is, what is the imaging difference between regenerative and dysplastic nodule?
Well, as I have mentioned, the regenerative nodule does not take, the enhancement on arterial phase, but usually in case of dysplastic nodule, it takes, sometimes heterogeneous or inhomogeneous type enhancement, and sometimes in case of dysplastic nodule, you can find some central cystic component as well in case of dysplastic nodule. But usually we do not find any this sort of cystic component in regenerative nodules. So I think we can differentiate on these points. Thank you.
Thank you, sir.
Thank you, sir. I am Dr. Fazal Karim. I have a question to Ghulam Mustafa, sir. We are doing FNSC from the liver cancer. Many times it is, as per your lecture, you have to need core biopsy for histopathology, immunohistochemistry. But from FNSC, is it possible to do immunohistochemistry? Because already the liver is diseased, so we cannot take core biopsy many times, many situations. It's not possible.
Thank you very much. Actually, from FNA, we cannot do immunohistochemistry properly. There are some situations where we can do. As for example, just we can give an idea that whether it is lymphoma or it is carcinoma. That is in extreme situation where there is no other way, we can do that. But ideally, we cannot do immunohistochemistry from FNA. But if you think prior, before doing FNA, if you think, then you can prepare cell block from the aspirate material, then it is possible.
How to do that, sir? Cell block,
Actually, cell block is a procedure where we can use the syringe washing. If there is any leftover material within the needle hub, we can use that material, we can wash that material, centrifuge that material and make a pellet. And from that pellet is then processed like a histology sample.
Oh.
So that is the cell block, and that cell block, if any diagnostic components are present, then we can use it as histology. So if you think that this patient will need those advanced options, you will have to think initially. Before putting the needle, you will have to decide that. And then you will have to plan that and then you can do that.
Thank you, sir.
You are welcome.
Thank you, dear audience. We were enjoying a very lively question answer session, but for time constraint, we need to end here. Learned audience, you can make question to the presenter personally later on. So we are almost at the end of our first session, and this is time for session chair. I would like to request Professor Chittoranjan Devnath sir to make some valuable comments.
Thanks to this organizer for giving me a chance to chair this session. In this session, there are three eminent teachers who described nicely regarding the radiological aspect, immunohistochemistry aspect, and the management of hepatocellular carcinoma. We know that if hepatocellular carcinoma is a great problem for the hepatologist, if you can early detect the case and then if you do minimally invasive procedure, then the patient's life can be extended. So we are very glad to know that every investigations are available in Bangladesh and management protocol are also available in Bangladesh. It's a great hope. And I think that under the leadership of our Honorable Professor Salim Rahman sir, we can serve the nation nicely and we can do well to the HCC patients. Thank you all. Thank you.
Thank you, Professor Chittoranjan Devnath sir, for your valuable comments. We have a very learned guest among us, Professor Shahara Haq, Head of Radiology Department, Dhaka Medical College. I would like to request her to make some valuable comments regarding this session.
Thank you, everyone, and good morning to everybody. This is the second international annual conference of Bangladesh Society of Liver Cancer Treatment and Research. I would like to congratulate the society president and everyone for organizing such a nice event. And I feel we're really honored to be here as a part of this session. Thank you, everyone. Just I'd like to comment one thing about that from our radiological perspective, you know that radiology is actually playing a very important role for diagnosis as well as management of liver cancer like hepatocellular carcinoma. And for diagnosis, yes, radiology very important, and triple phase CT scan of the liver that plays very, very important role for differentiating different kinds of liver tumor like dysplastic nodule, regenerative nodule, and the liver cancer. You know the regenerative nodules are the actually altered hepatocytes. So the maximum supply that comes to the liver through the portal vein normally. But in case of dysplastic nodule, as it is the pre-cancerous stage that is going to be a hepatocellular carcinoma. So it is supplied mainly by the hepatic artery. So the enhancement occurs early arterial phase due to this region actually in the dysplastic nodules, but hepatocellular regenerated nodule, the enhancement is actually non-enhancing. In some cases they may enhance it in some points. And the another thing that is very important to differentiate is the hepatocellular carcinoma and the hypervascular metastasis, that both the tumors are enhances during the early arterial phase. So this is a very important and challenging for the clinicians as well as the radiologists to differentiate these tumors, and the newer modalities like triple phase CT scan of the liver as well as MRI is playing and gaining its importance day by day and making very important diagnostic clue to differentiate these kinds of problems, as well as the other interventional radiology is coming up like TACE, transarterial chemoembolization, radiofrequency ablation, and these newer things that will actually make an adjunct to the diagnosis and management of the liver cancer. And actually this is a multidisciplinary approach. So radiology, pathology, hepatology and all discipline as well as oncology, when we will work together, I think the management will be far better and the patient will be gaining benefit day by day increasingly. And thank you everyone for giving me the opportunity to say something, and a very good morning to you all. Thank you.
Thank you, Professor Shahrokh Madam, again for making it more clear the difference between regenerative nodule and dysplastic nodule. And thank you her for giving us time from her very busy schedule. This is the end of our first scientific session, diagnosis and approach to HCC, and we are going to start our second session very soon. Thank you all the presenters and session chair for their participation. Thank you all again. Our second scientific session is surgery in HCC. So I would like to hand over microphone to a very renowned surgeon, hepatobiliary surgeon of Bangladesh, Dr. Akhtar Ahmed Shubho, Associate Professor of Surgery, Shohi Sohrawardy Medical College. Thank you.
Thank you, Dr. Roxana. So we are going to start our second session of today's second International Annual Conference of Bangladesh Society for Liver Cancer Treatment and Research. As we have already learned a multidisciplinary approach of liver cancer, in that multidisciplinary approach, we have a small part for surgeons to step in to treat the liver cancer. So it's our great pleasure of today's session because our chairpersons, we have two chairpersons among us who are the only two surgeons, hepatobiliary surgeons of Bangladesh, who have started this subject in Bangladesh from the 1990s. And these two renowned professors have established this subject in Bangladesh. Among the general surgery, this is a super specialty, and the specialty has been known from these two professors. First, I would like to introduce Professor Muhammad Ali sir, former head of the Department of Hepatobiliary and Liver Transplant, Bardem Hospital, to please take your chair, sir. Then also invite Professor Julfikar Rahman Khan sir, chairman, former chairman, Hepatobiliary and Liver Transplantation Department, Bangabandhu Sheikh Mujib Medical University, to take his chair, sir. We surgeons are very much proud that in fact the father of hepatobiliary surgeons are these two professors, and their long struggling and their service life has established our next generation of hepatobiliary surgeons, and we are getting ready for the next phase of liver transplant. So our presentation will start now. Our first presenter is Dr. H.A. Nazmul Hakim Shahin. He is Associate Professor of Surgery, Dhaka Medical College Hospital. and he is the most dynamic and most popular hepatobiliary surgeon of Bangladesh. In the next generation from Professor Muhammad Ali and Professor Zulfikar Rahman Khan, he will discuss on the liver resection for HCC.
Assalamu alaikum and a very good morning and welcome to second internal conference of Bangladesh Society for Liver Cancer Treatment and Research. I'm highly privileged and feel honored to be here and speak in front of our two legendary professors. Professor Muhammad Ali sir, উনি আমাকে হাতে ধরে কাজ শিখিয়েছেন, আমি এইটুকু আসার পথে ওনার অবদান আমি সারা জীবন মনে রাখবো। এখন ওনার ছায়াতলে আছি এবং প্রফেসর জুলফিকার রহমান স্যার, যিনি এই হেপাটোবিলি সার্জারিকে স্প্রেড করার জন্য, আমাদের মধ্যে সার্জন ক্রিয়েট করার জন্য দুইজন অবদান রেখেছেন এবং স্যার গভর্নমেন্ট সেক্টর, প্রাইভেট সেক্টরগুলো অনেক বেশি আমাদের সাবজেক্টগুলোকে আগার হেল্প করেছেন। সো আই ফিল অনার্ড এবং আমি ওনাদের প্রতি গ্রেটফুল। So now let us start our session, our presentation. Now presentation will be in the surgery in the liver cancer. Hope and scope. So as you know, the HCC is the most common primary liver tumor. Approximately about 8 lakh deaths globally per year, and the fourth leading cause of cancer death and sixth most common of neoplasia. Asia and Sub-Saharan Africa constitutes the high-risk areas. It is 3 times more common in male, and peak is incidence is 6 and 7 decades of life. As our Suleiman sir has already shown this thing, the incidence and the mortality all over the world. It is more common in the West Asia and Sub-Saharan Africa. More common because of the HBV infection and alpha-toxin B1. This is the study I've gathered from some journals in the Bangladesh. It shows us this is more common in Dhaka division and followed by the Chittagong division. And 60% association of the HCC will be hepatitis B virus infection in Bangladesh. What the main concern? The cirrhosis is the most determinant of HCC and can be caused by viral infection B virus and C virus. And now new conceptions, the non-clinical steatohepatitis nowadays has been grouped under the new name metabolic dysfunction as a fatty liver disease. This is the most emerging cause of the liver cirrhosis and the liver cancer. Diagnostic workup already told by our successors. As you know, the type C CT scan, the dynamic contrast enhanced MRI, contrast enhanced ultrasonography, alpha fetoprotein and FNSA2 cut in some cases. These two has most sensitive. So diagnosis is mostly based on the radiological findings and characteristics. As already shown, this contrast enhancement, the portal phase, RL phase, and the delayed washouts with the venous phase. FNEC, it is not always recommended in the oil capsulated, the radiological diagnosis is there, alpha beta rise. So FNEC is a minimum rule in diagnostic the hepatocellular carcinoma. Already it is almost 100% sensitive as well. So this is the modified. Before that, I need to this slide. It is the previous slide. In 2018, the BCC guideline was produced. In this case, it is shown that only BCC 0 and A is the suitable for the liver resection and the transplant. But in the modified in 2020, it is shown that the very early stage, stage 0, single lesion less than 2 centimeter is suitable for resections and ablation as well. In early stage, single lesion less than 3 centimeter or each lesion more than 3 lesions, but it's less than 3 centimeter with a preserved liver function and performance status 0, it is more suitable for the resection and the liver transplant as well. But modification comes in the intermediate stage, stage B. It is grouped in the 3 stages. In the early stage, the extended criteria can be included, and in some cases, the liver transplant is feasible. So these 2 modifications come in BLCC guidelines. How we proceed, or what are the things requirement for the liver resections? Surgical resection is recommended as the treatment of choice in patients with HCC arising in non-cirrhotic liver. Indication for resections of HCC in cirrhosis should be based on multi-parametric composite assessment of the liver function, portal hypertension, extent of hepatectomy, expected volume of future liver element, which is very, very important, performance status, and patient's comorbidities. All things should be considered during the approaching a patient in case of HCC in a patient. HCC-related macrobiotic invasion is a contraindicated liver resections. Now, liver function assessment, there are so many ways for liver assessments, child birth score, the Mayo score. indocyanin green kinetics, liver stiffness measurement, and cholesterol bilirubin ratio. There are other tools as well. And very important, this is CTP score. Class A, generally considered for safe candidate for liver resections. Class B can be proceeded with surgery after medical optimization but still have the increased risk. In class C, is not suitable for any resections. Presence or absence of portal hypertension modify our treatment opportunities. The clinically relevant portal hypertension, if the portal venous pressure getting more than 10 millimeter of mercury, it affects more in case of stage, but in liver resections, significant prognostic factor affecting survival in both surgical and medical patients with cirrhosis. So this is to bear in mind, and it is mostly diagnosed in radiological. So it is a graph showing if the portal hypertension is there, minor resections that is less than 3-6 segments can be with intermediate, but the major resection is in high risk. But if there is no portal hypertension, so both minor and major resections can be done. These are how we all, before planning for surgery, we usually do the angiogram at the arterial phase, this is the portal venous phase and the hepatic venous phase. So the planning is very important to actually determine the future liver volume. These are large lesions in the segment 7 and 8, so part of the 8. So when we are going for the 3D volumetry, we have seen that the volume of the liver lesion is 907 millimol. The volume remaining after 12,072 ml. But the most important thing, whenever we are planning for the resections, it is seen that this regarding the how far we should resect. If we resect the right lobe, right hepatectomy, and taking the middle hepatic vein, the FLR will be only 20%. So if without middle hepatic vein, it will be 27.12%. So only not of the size, the involvement of the venous drainage is very important. However, we are taking the middle hepatic vein or protein vein. So after assessment, it is saying that none of the resection is possible in this patient because of the large volume. And the principle is for the future liver remnant is to, in a normal liver, we can reach up to 80% of the liver. But in case of the chemotherapies, 30% liver research can be done. In cirrhosis, 60% liver research can be done. So very important to assure the actual liver volume and the tumor volume and the venous drainage of this tumor. This is ECOG performance status. BCLC categorized the patient with performance status 1, advanced stage of the SCC, and surgical research is recommended. Though performance status 1 is often not a contraindication to surgery for ACC. There is some controversy there, so not only the performance status is very important, other comorbidities, the liver volume and the portal venous thrombosis all should be considered during dissections. So for the surgeries, we did surgeries for the larger ones. Actually, I am showing the slides for you. Optimal resections with the resections are demonstrated in single lesions, but selected cases with 2 or 3 nodules may be considered for the resections. Tumor size is not a limiting factor, but the risk of recurrence is higher in larger tumors. Vascular invasion denotes an elevated risk of systemic recurrence. Patients with segmental vascular invasion may benefit from the segmental resections. This is some of the terminology we use in the liver resections. Right hepatectomy, known to you all, and extended right hepatectomy, left hepatectomy, on the depending on the number of segments, the medial intersectionotomy, posterior sectionotomy, all these are already clearly shown in the pictures. I'm not going into details of these nomenclatures. The Brisbane terminology actually. So in our center in Dhaka Medical Hospital, BADM, in private sector, so BSM and the Shakas Institute, large number of researchers are going on with our limited facilities. And we are using multimodalities like the KUSHA, the ultrasonic aspirator, then the LigaSure, Harmonic, and other Kelly's techniques are some used. In our series of 480 cases, in our series, 80% of the ACCs were resected in our this number of centers. So average our age was 51 to 50, 60 cases. This is one of the short videos. I'm not annoying you. The short video showing you are using the treatment modalities. These are left hepatectomy actually, having the tumors in the segment 2 and 3. We are using the Kelly's techniques. Is the for the hemostasis per argon coagulator. This is the, I'm just going all the techniques actually. And this is the CUSA and with the final resection of the left hepatic vein. And this is the ligature. So we sometimes do the anatomic resections, sometimes do non-anatomic resections. But the principle of resections is to, it is said that more than 1 centimeter of the clear margin is goes with a better outcome. But it is more appreciated for the segmented dissections because it also removes the involve the segments of the portal triads and the as well as sometimes there is invasion into the biliary channels. So all segment dissections are always preferable than the non-anatomic dissections. So these are some of my pictures of that showing this is the left hepatectomy specimen, and these are all the specimens of left hepatectomy. This is the large tumor in the segment 7, and we have dissected this tumor and these after dissections. We always approach the Grecian pedicle approach, and we have seen the clean line of demarcation for the right hepatectomy. This is the remnant after right hepatectomy. And this is also in the tumor with the right hepatectomy. This is a posterior sectionectomy. We segment dissected that recently. We have done this. This is the segments 6 and 7. We dissected that part. So these are others showing the non-anatomic dissections. Sometimes it is confusing what is it, a large ACC or the atypical hemangioma. So we go in for the dissections. In these cases, it came out to be atypical hemangioma actually. All those pictures of the dissections. And of course, the laparoscopic approach. In a properly trained centers, laparoscopic liver resection should be considered in especially the tumors with the anterolateral and the superficial locations. And we are doing it in a very limited cases in small tumors, mostly situated in the segment 5 and 6. We have already done 6 cases in our private sectors actually. I don't have the videos of this. And of course, some bridging therapies are there in the large volume. There is no option that treatment stage migration or the downstaging are there. If we plan for the large tumors, we can go for the TACE. And we have resected 3 cases of the liver after giving the TACE in our center. TACE, tear, and microwave, and stereotactic body radiotherapy is of course very important. Sometimes section I will stage liver resection there, ligation of the portal vein, and giving time to enlargement of the residual future remnant and go for resections. So all these are things which are we enable us to resect the large volume tumors. What about transplant? This is the 2 criteria for the Milan and extended University of California, San Francisco. So in the Milan, it is single lesion less than 5 centimeter, less than equal to 3 centimeter is less than 3 centimeter. But in the UCFC criteria, single lesion more than up to 6.5 centimeter is resectable. So other extended Milan criteria is also included. So this all should be considered in a presence of some of the performance status and the portal vein thrombosis and the other things. This is the last transplant we were done in 2019 with the Professor Subir Gupta and our team in Badem. We had done it for the actually non-cirrhotic liver, but you have not done any liver transplant in Bangladesh. Professor Julfikar Sar is one of the pioneer. Recently, VSU has done the liver transplant. So none was actually for the ACC actually. We go the other causes are there. So in conclusion, it may say that preoperative planning, anticipation of the possible vascular biliary anomaly should be top priority. Perioperative preparation, selection of the patients, medical surgical techniques, and key to the successful outcome. Thank you all for patient sharing.
Thank you, Dr. Najmul Hakim Shaheen. I would like to call on stage our second speaker. We have to give a short brief of him. He was born in Birmingham in 60 years back. Still, he is a very young man. He is among us in our first line. He started his medical graduation in India, All India Medical Institute, and did his master's there. Then he went to UK and did his double FRCS in surgery and transplant surgery. And he started liver transplant in UK, and then he came back in India 2000, and up to 2010 he was in Sar Gangaram Hospital, and from then he is in Medanta Hospital, now, and a short magnetic part. He is the first successful liver transplant surgeon of India. He has been doing more than 250 liver transplant in every year and has done more than 3,500 liver transplant in the past. In the number, he is the #1 in India and #2 in the whole world. In this subcontinent, he did the youngest liver transplant, 6 kg baby, got liver transplant from him, 11-month baby. And he did liver transplant in 78-year-old man also. And he is the first living donor liver transplant surgeon in India also. A lot of things, and he got few rewards also, like Padma and a lot of rewards from India and UK. And it's our privilege that he is among us today. So I would welcome Professor Arvind Singh. Please come on the stage, and he will deliver a few speeches on liver transplant.
Hello, Professor Mohammad Ali. Good to see you. Thank you. Thank you for that very kind introduction. It's always a pleasure to be here amongst friends. Professor Salimur Rahman, Professor Zulfikar, Professor Muhammad Ali, these are all friends for a very, very long time. Many of you present here, we've met a number of times in conferences in India, at Medanta or abroad, and of course in Dhaka. This is probably my 5th or 6th visit to Dhaka. Always a pleasure. It's like home, basically. So, like I said, thank you very much for the kind introduction. There are a few facts in the introduction that I'd like to point your attention to. So I actually moved back to India in 1998 to Apollo Hospital. And we started liver transplantation in India for the first time at Apollo Hospital. So I was there for 3 years, from 98 to 2001, and then I moved to Gangaram and then, of course, Medanta Hospital. So I moved to Apollo Hospital, India in March of 1998, and we struggled for 7-8 months because we didn't get any cases referred to us by the gastroenterologists or surgeons or any physicians. Whichever patients came our way, we tried to convince them to have transplant. None of them would have it. Then we convinced someone to have a transplant in May. And one of my colleagues there, Rajshekhar, who was already there when I joined, he and I decided that we will do alternate cases. So he will do one case, I will help him, and then I'll do the next case, and he will help me. So that's how it all started. So in May, we planned a transplant, but it never happened. And then November 1998, 5th of November, we got a cadaveric donor within the hospital. And I transplanted a 43-year-old gentleman with alcoholic liver cirrhosis, who was from Delhi itself. The transplant went well, and the guy got discharged in about 12, 13 days. So that was India's first successful liver transplant. He lived 9 years pretty happily. Then he went back to alcohol and died 4 years later. So he survived 13 years and died of alcohol recidivism. Obviously, there was no question of retransplanting him. The second successful transplant was the first pediatric transplant of India, which I did on Sanjay Kandaswamy, a 19-month-old boy from South India. His father donated the left lateral sector for him. He was a tough transplant. He was very sick. He had had a previous Kasai operation. So anyway, stormy surgery, stormy post-out, of course. He was in the ICU for 2 months. And myself and Rajshekhar were sleeping in the ICU for 2 months on alternate nights. We eventually got him out. He's 26 today. He's 6 foot tall. He's a doctor. And he works in Bangalore now. So, you know, that's the journey, that's the beginning of the journey, and now we've done about 4,100 liver transplants. About 650 or 660 of those have been liver cancer. So I'll take you through our experience of liver transplantation for HCC with cirrhosis. So why a liver transplant? With liver transplant, obviously the underlying cirrhosis is cured. The undiscovered multicentric lesions and later recurrent lesions or de novo HCC, as may happen with HPV, they're all treated. The later risk of recurrence for HCC, especially in hepatitis B, is about 50 to 80%, and that is avoided. Obviously provides the widest oncological clearance, and it affords accurate pathological staging. What about resection? My friend has just alluded to resection for liver cancer. And obviously what has happened is you've seen that 468 cases have been done in their center in the last 9 years, which is very creditable. And so there is improved surgical technique, which is more widely available. There is minimal access surgery with laparoscopic and robotic techniques. So all these help the case for resection for transplant. Obviously, liver resection is cheaper. It's an immediate solution. There's no waiting for the donor. It can help selected patients for liver transplantation. It can help select patients for liver transplantation when you base your transplant decision on the tumor histology, grade, and markers, all of which you get once you've done the resection. It's obviously more widely available than liver transplantation because no transplant expertise is needed. And theoretically, if there is recurrence after resection, you can do a salvage transplant. So those are the advantages of resection. Now, what do we do at Medanta for pre-surgery workup for both transplant and resection? We would do a triple phase CE-CT scan or a dynamic MRI with hepatobiliary contrast as a basic investigation for all these patients. We would do routinely alpha-fetoprotein and DCP or PIVCA2. We would do a whole body FDG18 PET scan because we find that 62% of our patients take up FDG, the tumors, and if they take up FDG, then it's a poor prognostic sign, and it's also useful in monitoring these patients after surgery. We would do a whole body bone scan, and we would do, if there are suspicious lymph nodes in the mediastinum or the abdomen, then we would do a EUS FNA, FNA-C usually, like we discussed in the previous session. FNA-B or cell block is occasionally possible, but not optimal for immunohistochemistry. So when we are thinking of resection, we would assess the liver quality and quantity for resection. So you would look at the CTP. Usually we take up CTP A patients or B patients for resection. You look at the MELD score, you look at HVPG, and those with 10 or less mm of Hg HVPG are good risk. ICG clearance, less than 10% retention, again, good. And volumetry, ballpark rule is you should try and leave 50% if you're doing cirrhotic resection. UCSF criteria, everybody knows. If you transplant patients within the UCSF criteria, the yield survivals of 1 in 5 year at 90 and 72%. Now, what about liver transplantation for HCC? Where there is no controversy, it is basically decompensated cirrhosis and HCC within UCSF and patients who are bad risk for resection. So there is no controversy that these people need transplant. However, the controversy arises when you're looking at less than UCSF, that means within UCSF criteria, who are actually good candidates for resection. That means they have 1 or 2 lesions on one side of the liver that can be conveniently resected. That's one area of controversy. The other is expanded criteria. So the deceased donor liver transplant programs and clinicians do not believe in expanded criteria much, although they have also expanded their criteria, but the living donor liver transplant world believes in expanded criteria. And of course, there is a lot of controversy on advanced HCC with vascular invasion. Now, why do we need to extend beyond the conventional criteria? Everybody knows conventional criteria, good results. But there are many patients who would be benefited who are beyond criteria if they actually had transplantation. Now, it's pretty clear that in LDLT there is no competition for the donor liver, there are less dropouts because of disease progression, and there is a survival advantage probably of 2 to 5% with a better graft. That's established in all centers that do DDLT and LDLT concomitantly. Generally, Mazzaferro himself, we have co-authored several papers, he himself believes, he's the one who propounded Milan criteria, and he himself wrote that conventional Milan criteria are too restrictive because they exclude many people who would benefit from liver transplantation. So he published this about 14 years ago. He published his original Milan criteria about 1996, so that was 23 plus 4, 27 years ago. But this was published about 14 years ago where he said that if you look at tumors, which are large number of tumors and large size of tumors, you can still actually have close to 50% survival at 5 years or if the tumor is like 10 centimeters and you have 10 tumors, as long as there's no vascular invasion. And even when there is vascular invasion, you can actually have 25% survival. Now that means that every person with a large number of tumors and a large tumor, the largest size being more than 6 centimeters or 6.5 centimeters, is not actually bad enough biology to mean systemic spread and poor survival. So some of them will survive. The trick is to pick out these people who will survive long term. So our policy at Medanta has been living donor liver transplantation for all HCC and cirrhosis if there is no extrahepatic disease, if the main portal vein, the right, the left portal veins, the hepatic vein, and IVC are free of tumor, there is no medical contraindication to transplant, and this is irrespective of tumor size and number. So all comers in terms of number and size. And let's look what that has done for us. So we published this a couple of years ago based on our experience of this policy, which I just spelled out. And we found that at that time we had looked at about 2,350 transplants, out of which 451 had had liver transplantation for HCC. Now this number is 4024 as of March, and 682 of these 4024 transplants have been for HCC. So amongst these 450 that were looked at in the published paper, 46 were enrolled into the downstaging protocol for portal vein tumor thrombosis, whereas 405 had HCC with cirrhosis without any PVTT or portal vein tumor thrombosis. About half of them were within and outside of Milan, and about 60% were within UCSF and 43% outside of the UCSF. So we found that we had 10-year survival of 55% among all these patients and a recurrence-free survival of 67%. So this is how we justify our policy of all comers. Now, we tried to separate this cohort of patients into groups that would be low risk, medium risk, or high risk, depending on biology, because everyone understands that tumor biology is now the king. That's how you decide whether a patient with HCC and cirrhosis will do well or not after treatment. So we found 3 factors. Beyond UCSF, AFP preoperatively of more than 100 nanogram per mil, and FDG18 avidity. These were the 3 risk factors in our series. And if there was one factor, we called it low risk, 2 factors, we called it medium risk, and all 3 factors, we called it high risk. And we found that if they had no factor or 1 factor, their survival was like 90% at 5 years. If they had 2, then survival was 71% at 5 years, and if they had 3, that's the high risk group, the survival was 41% at 5 years. So the recurrence was 9% in the low risk group, which is similar to quoted series from the West on DDLT in UCSF type criteria. And moderate risk had a recurrence rate of 25%, and high risk had a recurrence rate of 46%. So I will show you later when I talk about downstaging, how we use this data to manage our patients currently. So with this policy, we also found that over TACE and TARE, liver transplantation has a huge transplant benefit at 36 months of 27 months and at 60 months of 42 months. And even in the high-risk group, there was a incremental transplant benefit of 17 months and 25 months respectively at 3 years and 5 years. So transplant benefit basically means the additional delta of survival that you get with transplantation compared to alternative treatments. So compared to TACE, TARE, local ablative therapies, our policy of transplanting these locally advanced cancers gives patients significant transplant benefit. These are the expanded criteria in DDLT. I'm not going to enumerate each one of them, just to say that they extend their criteria to up to 7.5 centimeters in the various systems. And each of these series had from 30 to 1,500 patients, and they achieved overall survival at 5 years of 52 to 83%. Apart from Medanta, the other expanded criteria in living donor liver transplantation, again, are multiple, and they've had 70 to 200 patients in their series. They've had overall survivals of 75% plus at 3 to 5 years, usually 5-year survival. And these outcomes have been comparable to within Milan. And now these are the LDLT criteria where people have included biology, which means they include DCP or PIVKA2 and AFP, both actual values as well as delta before and after downstaging if relevant. So again, they've been able to obtain these kind of survivals. So these are the biological criteria that you should look at when you're prognosticating HCC cirrhosis patients with reference to transplantation. So AFP, PIVKA2, PET, FDG18 avidity, downstaging, achieved or not achieved, waiting period, because obviously that's a surrogate marker of biology. If the waiting period does not make the disease progress, then obviously you're dealing with a good biology. And then neutrophil lymphocyte ratio, platelet to lymphocyte ratio, count ratio, histology, molecular criteria. I mean, so much has been written about them, but there is no standard molecular diagnostic criteria or prognostic criteria at this point. So this is just a paper to show that the negative PET guys do much better than the positive ones, both in terms of overall survival and recurrence-free survival. This is a publication from Professor Zeng's group. Now this is an interesting one. It basically says that inflammatory markers is a bad thing for cancer recurrence. So if you have a high neutrophil to lymphocyte ratio or a high CRP, these guys do worse. So the 0 ones are the ones who have none of them. 1 has 1 factor and 2 has both factors. And as you can see, the disease-free survival and overall survival falls as the inflammatory criteria, are met in terms of people having high inflammatory markers. This is the platelet count, lymphocyte count ratio. Again, if it is less than 120, that's a good thing. But if it is more, then that's a bad thing. Train score, this is a study we participated in. We've actually had 4 or 5 publications out of this. TRAIN stands for, it's an acronym that stands for waiting time. The T stands for time. Radiology, AFP, inflammatory score. So the Eastern and Western data were joined into a couple of these publications, and basically using the TRAIN score as opposed to conventional Milan or UCSF, 8 to 24% extra patients were transplanted without compromising results. So basically you were able to expand criteria using the TRAIN score without compromising survival. Now, what happens if there is a recurrence? We've actually shown that recurrence in post-liver transplant patients is not actually the end of the road. And we are able to achieve 1 and 3 year post-recurrence survival of 57 and 24%. And we've actually had a maximum post-recurrence survival of, at that time it was 7.5 years. This patient is still living. So it's about 10 years now. So again, it's all biology. So if there is a recurrence after transplantation, I routinely counsel my patients that, look, you're a moderate risk. You may have 15-20% chance of recurrence. Recurrence usually happens within 2 years. And if you have a recurrence, there is a 50% chance that you'll survive 2 to 3 years after that. So this is how it helps you. If you know how you can treat recurrences after transplantation, you can counsel them upfront when you're taking them up for transplant. So to summarize the experience of LDLT for HCC cirrhosis with expanded criteria, 80% patients live a long-term life without recurrence with a 3 to 5 year overall and recurrence-free survival in the region of 70 to 80%. At Medanta, we've had 5 and 10 year survivals of 67 and 57% overall, and 74 and 67% recurrence-free, with our all-comers policy for number and size. And it's quite clear that living donor liver transplantation is still the best curative strategy, even for patients beyond UCSF. And alpha-fetoprotein, PIVKA2, and microvascular invasion are prognostic, and they can actually indicate neoadjuvant and downstaging therapy requirements. Now, we published this, I and my group, ILTS group. I was in charge of this group for making the consensus guidelines about 4 years ago. We had a meeting in Rotterdam, and we came up with these guidelines, which basically said that, yes, the selection criteria for LDLT should be different from DDLT. With good biology, with validated selection criteria based on AFP less than 400, FDG non-avid tumor, DCP, that's PIVKA2 less than 400, response to local regional treatment according to Morrell or TRAIN scores, and HALT. Now, these are all scores that include these criteria. The criteria may be extended beyond UCSF size and number, provided there's no extrahepatic disease and microvascular invasion. So this is the recommendation of the ILTS consensus group. But at the same time, when you're doing LDLT, you have to maintain the double equipoise of living donor liver transplantation, which means to achieve maximum recipient survival with minimum donor harm. So the survival is pegged at overall survival of 60% at 5 years. That is what justifies living donor liver transplantation. A word about downstaging, with and without portal vein tumor thrombosis. That means with macrovascular invasion and without macrovascular invasion. The category of without macrovascular invasion, that means without PVTT, was popularized by this paper 15 years ago by Francis Yao, my dear friend, from MSKCC. And they basically, what they did was, sorry, he's at UCSF, sorry. And what they did was that they downstaged HCC, which was up to 8 centimeter, and 2 or 3 lesions not exceeding 5 centimeters. So these were beyond T2 or these were beyond UCSF. And they were downstaged to within T2 or UCSF. And they basically had excellent 1 and 4 year survivals of 96 and 92%. And they behaved like patients who were de novo within T2 and UCSF. So basically downstage patients behaved like original within UCSF patients. And this is what basically started this whole story of downstaging, which everybody now believes in. In our system, if you recall the table that I just showed you, where there was low, moderate, and high risk depending on AFP, FDG avidity, and UCSF. So the low risk people who are 0 or 1 factors present can have upfront LDLT. The moderate risk people who have 2 risk factors should ideally have downstaging, and high risk patients should also have downstaging. So moderate and high risk should ideally have downstaging, and that's what we try and practice in our system, unless the decompensation is so bad that they can't wait. Now, what about people with portal vein tumor thrombosis? We've just talked about people who don't have portal vein tumor thrombosis, but they have advanced local disease. But what about those who do have PVTT? Now, median survival of untreated PVTT is 3.7 months. That's it. And recent evidence is that selected patients with portal vein tumor thrombosis can be downstaged and transplanted, and let me show you that evidence. So, first, let's understand what tumor thrombosis we are talking about. So, according to this classification, VP4 is the involvement of the main portal vein, VP3 is the involvement of first order branches, VP2 second order branches, and VP1 beyond. So that's the terminology that you use to say what level of tumor thrombosis the portal vein has in a patient. So we had this published by Kwangbo Lee's group from Korea in about 7 years ago, where they found that 11 out of 282 patients with major PVTT actually were transplanted, and they had 1, 3, and 5 year survival rates of around 45 to 50%. And they found that VP4, high alpha fetoprotein into PIVKA2, high SUV on FDG PET, and tumor more than 7 centimeters were risk for, they were the risk factors for recurrence. But they actually had 11 patients who had approximately 50% survival, and they had not treated them with any downstaging. So this went on to show that there was some cohort of patients who, despite macrovascular invasion, could live long-term after transplantation. Now, this paper is from Asan Medical Center, Seoul, and they actually downstaged PVTT in 17 patients and again achieved good survivals of around recurrence-free of around 86 and 74%, 70 and 57%, and 87 and 60%, depending on whether they looked at the intrahepatic recurrence-free survival, disease-free survival, and overall survival. So basically, again, they showed that downstaging PVTT can result in good survival after transplantation. So now, I recently wrote this review and debate in Journal of Hepatology, and there we showed, it was actually a debate. So I was supposed to argue in favor of transplanting patients with PVTT after downstaging. And I based my arguments on 4 things. One is that PVTT should be considered to be loco-regional rather than systemic spread unless proven otherwise. So you can't say somebody has PVTT, they have systemic spread. And then tumor in the portal vein thrombi can regress or completely go with radiotherapy. That's been shown by multiple groups. And then long-term survival is achievable in HCC PVTT after downstaging with radiotherapy followed by liver transplantation. This is the core of the paper that we published recently that I'm going to talk about. So that means long-term survival is possible after downstaging PVTT. And also, there is a clear survival benefit or transplant benefit in transplanting these patients. So this is the paper we published. This is amongst the highest quoted HCC papers in the recent 5 years. So we published this paper on how to downstage these patients with PVTT and then transplant them. So again, here the cohort was 465 patients, no PVTT in 410, PVTT in 55, 30 were transplanted without radiotherapy because they were VP1 and 2, and 25 were transplanted with downstaging after radiotherapy, that they were VP2, 3, and 4. Our protocol is that you do a CT scan triphasic, you do a PET CT, and if the patient is Child's A or B and have a more than 70% non-tumor liver remaining, then you subject them to TARE and SBRT. So we would normally do TARE 1, which is, of course, the macroaggregated albumin scan and the angiography to see if there are any shunts. And then we would put in fiducials for CyberKnife SBRT or stereotactic body radiation therapy, and then do a sandwich SBRT for a week or 5 to 7 days, and then do TARE 2, which is actually injection of the yttrium-90. So the SBRT given is about 45 to 55 gray. And then after all this is over, this can also be done in the reverse or in another sequence. You would do TARE 1, TARE 2, and then SBRT. You do it both ways. You response evaluate at 6, 8, and 10 weeks, and you proceed if there is no FDG uptake and there is no arterial enhancement. And then you repeat SBRT if there is partial response. So we've done this over and over. Now nearly 80 patients have undergone transplant after this protocol, of course, much more since the publication. And we again found that 57% of our patients actually had 5-year survival. And this is patients with portal vein tumor thrombosis. So, and compared to alternative treatments with palliative radiotherapy or sorafenib alone, there was a huge transplant benefit at 36 months of 23 months. That means within 3 years, you gave 23 months better survival to patients with transplant compared to palliative therapy. So this is a consensus statement, guideline statement by INASL, the Indian Association for Study of the Liver. And we focused on the intermediate and advanced stage HCC in this consensus. And these are the statements that they issued a few months ago on HCC with PVTT without any extrahepatic disease. There is no transplant for extrahepatic disease, but without extrahepatic disease in PVTT, there is transplantation. Now, resection in selected patients with HCC and ipsilateral PVTT with ECOG status 0, 1, or 2, or Child's Pugh A, no extrahepatic disease, when the primary HCC is resectable and there is moderate residual liver function reserve. So that's resection. Then HCC with major vascular invasion is an absolute contraindication for upfront LDLT, so or LT. You cannot do liver transplant upfront. You have to downstage them. So in selected patients with PVTT with segmental and sectoral HCC without extrahepatic disease, and a favorable tumor biology in terms of AFP, FDG PET, liver transplantation may be considered post-downstaging using TARE, SBRT, and TACE, and disappearance of macrovascular invasion after an appropriate waiting period. So this is the current recommendation of INASL HCC group. A word about salvage transplantation. The results of salvage transplantation versus primary transplantation, that's the first thing to consider. Then you must understand what proportion of patients that recur can actually go through a salvage transplant, and what is the eventual outcome of patients with HCC on an intention to treat basis. That means you start with 100 patients who could have resection or transplant. You subject 100 to resection, the other 100 to transplant. How do they behave differently over a length of time? So our own experience, 2004 to 17, 14-year experience, 2,300 patients, 452 liver transplants, confirmed on biopsy 448. Liver resections during the same period, well, similar period, 374. Resections for cirrhotic HCC, 143. So 78, on which all kinds of data was available, we considered that they underwent resection, but they could be transplanted. Out of these 78, 41 recurred at 3 to 28 months. Mean was 12 months. 19, that means 46, were transplantable without extrahepatic disease or major vascular invasion. And 12, which means 15% of the original LRT group, or 29% of the recurrence group and 63% of the transplantable group ultimately underwent salvage transplant. What does this mean? This means that out of 78 patients that underwent resection that could have been transplanted, only 15% underwent salvage transplantation. So it's almost a myth that go ahead, do a resection, you can always do a transplant later. It only happens to 15–20% patients. Our own experience. Although the operative mortality was 0, so they did quite well with salvage transplantation. In the short term, 5 recurred at 6 to 72 months, so that was slightly higher recurrence. That means 5 out of 21 patients, about 25% recurrence, slightly higher than the usual de novo transplant patients. So Belghiti also published similar results where only 28% of his series were transplantable and 65% of the patients, 2/3 of them recurred in 31 months. So he also didn't have a good experience with salvage transplantation. So to summarize, operative mortality in salvage transplant is similar to primary transplant. Recurrences after resection usually occur within 3 years. Recurrence is usually more advanced than the primary cancer. Less than 1/3 of those with recurrence would eventually be suitable for salvage transplant. And on an intention to treat basis, disease-free survival after salvage transplant is way inferior to primary transplantation. Resection, I'm not going to talk much about, it's already been discussed. I just want to say, Prashant, one of our senior surgeons, published this paper about 10 years ago. And they showed that resection versus transplant for HCC cirrhosis less than 5 centimeter, they had a better overall survival and better recurrence-free survival. And that the overall survival for less than 3 centimeter resection versus transplant was the same or similar, but recurrence-free survival was better with transplantation. So transplant scores over resection in most of the situations where resection and transplant both are possible. So I'm concluding finally to say that liver transplantation is the best option for cirrhotic HCC within UCSF. No controversy there. Liver transplantation, especially living donor liver transplantation, is the best available treatment for advanced HCC cirrhosis without extrahepatic spread or vascular invasion, irrespective of size and number. Early HCC liver transplantation is better on at least recurrence-free survival on intention to treat basis than resection alone or salvage transplant. Salvage transplant may only be applicable to 1/4 or 1/3 of the patients, and short-term results, although they are the same as primary, long-term results are inferior, and intention to treat results are definitely inferior. But resection still has a place for non-cirrhotic HCC, for child's AHCC, for those with insignificant portal hypertension, and unfavorable logistics for transplant. Then, when you're transplanting HCC cirrhosis, you must think morphology, biology, and molecular markers. Morphology, everybody knows. Biology, most of us know now. Alpha-fetoprotein, waiting period, response to local therapy, PIVKA2, FDG. And then molecular markers, we hope to know in the next 10 years. They should all be used in decision-making for transplantation. Conventional size and number criteria need to be buried, for sure. Strong association of alpha-fetoprotein, PIVKA2, FDG18, NLR, and histology with the outcome of advanced HCC after transplant, and these should be used to select patients. Downstaging of advanced tumors is beneficial and should definitely be done. Selected patients of PVTT derive benefit from transplantation after downstaging. And of course, molecular markers need to be defined. And everything I have said is thanks to my team. Some of them are here, but of course we have a very large team, and I'm grateful for them for their camaraderie and support. And thank you all very much for patient listening.
Thank you, Professor Arvind Singh Soin, for delivering his state-of-art lecture. Sir, can you please take your seat?
Thank
please?
you.
The lecture was really an art. We were waiting for a liver transplant lecture, but it was really beyond liver transplant. The idea of HCC operability and the portal vein thrombosis, the way Dr. Soin was presenting, in fact, is there anything contraindication? I don't know. Everything will reach under indication in our future. Now it's open for everyone to do any question for the two speakers. Please, Dr. Anwar has raised his hand. Please go to the mic. Pechone je mic. সময় কম এজন্য আমরা আসলে যত শর্টে করতে পারি দুইটা কোশ্চেন হ্যাঁ
Thank you, Dr. Shubhai, for his nice anchoring, and really it's awesome. And thank you, the Society and Farooq sir and Salimun Rahman sir for this beautiful program. I have basically two questions. One for Dr. Nazmul Hakim Shahin sir. Sir, it's a very wonderful presentation by you. I have a question, two questions. Number one, does you practice ICG clearance test for pre-operative preparation of liver resection in your practice life?
Thank you. Actually, we don't do this. We only depend on the CT volumetry and of course the CT angiogram to planning for the resections for the larger tumors.
Okay. Another question is, in your practice life, how you faces the recurrences of SCC after liver resection?
In the small size, less than 3 centimeter, recurrence is very few, only 5 cases out of my 95 cases. But in larger SCC, large tumors, yes, recurrence rate is high. It is like 10 already have the recurrence. All the de novo new onset of the other part of the tumor.
Thank you. Professor Soin sir, I have a question. Really, I met you in 2020 when I was a Grand Burman Fellow in Gangaram Hospital. I heard your name from Professor Nondisa lots of time. Sir, I have a question for you out of this slide, that in your early life, when you started liver transplant in India, what is the mortality rate or what is the outcome in your early life in India? And do you face any struggle in India that time, and how can you overcome for that?
Are you asking about early mortality?
Yeah. In your early life when you started Gangaram in liver transplantation?
In our initial cases?
Recently, yeah. Last cases.
Okay.
Yeah.
I don't like to talk about that in public.
But you overcome the situation.
Yeah. No, so I'll be honest. I was in Apollo from 98 to 2001. We did 22 cases when I was there for 3 years. We had a 66% survival. Okay. So obviously that wasn't good because I came from Cambridge where even in those days there was 90% survival, even in the 90s.
Oh, okay.
Yeah. And then I moved to Gangaram Hospital, and so I moved in 2001. And we did our first case actually 2.5 years later because we were getting set and arranging everything and all that. So I must tell you on a different note that the first 5 years of my career in India after returning from UK were very, very frustrating.
Okay.
It was not easy at all. I mean, although we did a bunch of cases and first this and first that, but we weren't actually running a good program because referrals were far and few and people's belief in you was not much, and you're always fighting with the hospital management to give you space, OT space, and then you lose patients and the relatives get upset, the media gets upset, so it was very hard. But you know, I think perseverance and building a team are the two key things which saw us through eventually. So by 2006, we had done about 32 cases, and if you discount the first 4, we actually had about 88% survival, which I presented at the ILTS meeting. And so by the time we were done in 2010 with Gangaram, we had done about 540 odd cases. So we really got going after that. And we were routinely getting 88, 90% survivals. And so I think when you deal with mortality, it's multifactorial. Obviously, what happens is that you select, part of the thing is selection of patients. And your backs are against the wall, you're supposed to deliver, hospital management, your colleagues, your department, everybody is looking up to you to, and of course patients, to deliver. So the pressure is very high. You select, sometimes you stupidly select bad patients who don't do well. See, now we are able to take all kinds of patients, high-risk patients, low-risk patients, because it doesn't matter if the patient is high-risk, because they're not going to be transplanted elsewhere. You still save 7, 8 such patients out of 10, so it's fine. But those days, if you only took high-risk patients, then obviously you had very bad results. So I think building a team, persevering, spreading the message with academic sessions and frequent meetings amongst your colleagues, physicians, gastroenterologists, hepatologists, all this slowly has effect. So now, of course, for the last 400 cases, our operative mortality is only 3%. So we've had 97% survivals over the last 380 odd cases. We just looked at it last week. And so you slowly improve. There's no shortcut or there's no magic.
Okay, so last question for you. So what is your advice for the young upcoming liver transplant surgeon in Bangladesh who wants to be liver transplant surgeon like you? What is your advice?
So 2 pieces of advice. I'm not going to tell you that hard work and honesty and all that, everybody knows that. But basically you have to train in high volume centers. So young surgeons who want to do liver transplantation must spend 2-3 years in high volume centers. When I say high volume, people doing 200, 250, 300 cases like ours, like Rela's, Subhash. There are these 3-4 centers which are well known. So you must spend some 2-3 years in a high volume center. That's one. Because then you will go through the whole gamut of risk categories, as well as decision making, as well as complications, judgment. All those things will only build up when you have 500-700 transplant cases under your belt, not necessarily having performed the cases, but at least experience the whole perioperative care of these 500-600 transplants. So that's the first piece of advice. And the second is you can't do it alone. So you must weave yourself into teams, and the team has to be a core team of 4, which means surgeons, hepatologists, critical care, and anesthesia. So that's the core team. You must build up that team, and everybody in the team must train in ideally high volume centers. And of course, good radiology, pathology, blood bank, all that dialysis support, neuro and cardio. So these are basics that should be present in any center. And then first few cases should be simpler cases. Don't take up very high risk cases. That is a few pearls of wisdom that I've gleaned over my last 30 years of practicing liver transplantation.
Okay. Thank you, sir. Thank you, sir.
Thank you. Dr. Anhar, for your very time-demanding questions. And thank you, Professor Soin, sir, for your nice reply. It will be encouraging for our surgeons of Bangladesh. Now it's time for our chairpersons to give a short note towards the audience. At first, I want to welcome Professor Zulfikar Rahman Khan, sir. Please come to the stage and give a valuable opinion regarding these 2 presentations, sir.
Thank you very much, Dr. Shubha. First, I like to thank Professor Selimur Rahman, the President, Bangladesh Society of Liver Cancer and Treatment, for inviting me and to share a session. It's very important and a luxurious and gorgeous session, because Dr. Soin was one of the presenters here. I know Dr. Soin for last 15 years, I think, 15 years. And I just like to share one of my experience with him that, this will reflect the hard-working attitude of a surgeon. And I think it's 2009, I went to Delhi in Sir Gangaram Hospital to see his transplantation. And one day morning, I observed his operation, and I went back to hotel in the noon, and afternoon I was observing the TV. And there was a live program of the award ceremony. Then just as I was observing, then I came to know one name, the Aurobind Singh Soin. They called Aurobind Singh Soin. Then I saw that Dr. Soin is taking the Padma Shri. In the TV, I saw him in the afternoon, and morning he has done a liver transplant. So I was surprised that if it had been our country, what would have been? I mean, I can say in Bengali, আমাদের যদি দেশে কেউ পদ্মশ্রী ওই দিন পাইতো, তে 3 দিন থেকে সে কাজ করতো না, এবং যেদিন উনি পদ্মশ্রীটা পেলেন, next morning also I saw him, he's operating again. In the theater, no news, nothing, no shout, no flower bouquet, nothing. And it would have been in our country, next 4-5 days, he would stop the work and হাজার হাজার ফুলের মালা তার কাছে আসতো এবং সে এটা রিসিভ করতো। তো ফলে that is a very important thing, the hard working attitude of a surgeon should be. And that has surprised me. And I have seen his hand, he is an excellent surgeon. And he has also helped us to develop this program in Bangladesh. And there are many reasons why we could not succeed. I don't want to discuss all these things. But the two things Dr. Soin has told us, that the training is very important. Training, you must work in a center, high volume center for a long time. And another is dedication. And another advice was given by Dr. Rela to me, that don't go for advertisement. That we could not stop. Don't go for advertisement, do the job silently. Success will automatically, people will know the success. Dr. Rela was giving me advice. But in our country, I don't want to criticize ourselves, but there are many loopholes from our side. But what I felt that we need a manpower. So that's why we have opened a course in the hepatobiliary surgery in Bangabandhu Sheikh Mujib Medical University. And we have so far, I think, 20 MS students. They have done MS in hepatobiliary surgery. And we are planning to send them for a center, high volume center, to work there, so that when they will come back, they can start this surgery here. And I like to thank Dr. Soin that he has helped a lot to our junior surgeons to develop this subject, hepatobiliary subject, mainly liver surgery and liver transplantation ideas. So I'd like to thank Dr. Soin once again. And regarding the first paper presented by Dr. Shaheen, actually, you must have a good liver surgeon first. Then you can start liver transplant. So and he has done a lot of liver surgery, so I think they will be able to do liver transplant in future. Thank you very much once again.
Thank you, Professor Zulfikar Rahman Khan, sir. He is the academic guardian of hepatobiliary surgery of Bangladesh. We all have gone through his teachership, and we has completed the masters under his plan and guidance. So in this stage, I want to inform another point of Dr. Soin, sir. On his delivery, he was telling that in the first part, there was some frustration, some struggling time. And what I know is, he himself told me some other day, that he even did the kidney transplants for those times to pass the time, those tough time, because liver transplant was not been available that time. He was frustrated, what to do. Then he started kidney transplant in India.
True. I didn't start it, but I did kidney transplantation to keep myself busy. And, and I even had trouble there. So people were already established in kidney transplantation, and I was a relatively young guy who's come from UK and wants to do kidney transplant. Nobody is letting me do kidney transplant. So then what I did was I went to Baltimore and University of Maryland to train in laparoscopic donor nephrectomy, because I thought I should offer something different. So I went and trained in laparoscopic donor nephrectomy, and then I started my laparoscopic donor nephrectomy program, which incidentally also is a procedure I did for the first time in India. Nobody else did it before that. So that's how I was able to start kidney transplantation. So I took a very circuitous route: liver transplant, laparoscopic donor nephrectomy, kidney transplant, back to liver transplant.
Thank you, sir. Now I'd request Professor Mohammad Ali, sir, for his speech to our two presentations, sir.
Thank you. I'd like to thank Professor Salim Rahman for inviting me for this session. It's really, first thing, this organization is a wonderful one, which I appreciate, because liver cancer is a deadly cancer, and it needs a multidisciplinary approach. And what he has done, he had combined together all these multidisciplinaries under the same umbrella and doing wonderful job. I am very fortunate that I was present in his first meeting, and I am also here in the second meeting. So I wish great success of whole endeavor of this organization. Next, most important thing is Professor Sohan, and his world, not only in India, he's world-renowned liver transplant surgeon, and I am very much fond of him. He is very much authenticated. I read most of his publications, and I'm fortunate. I met him in Sargam Garam Hospital 19 years back, when one of my